and CEO and founder of Deuk Spine Institute. We're here today. We're having internet issues, of course, so we appreciate your patience while we deal with it. Our patient here that we're doing surgery on, and you're watching a live stream of spine surgery from Deuk Spine Institute. We've been live streaming spine surgery now for 6 years. We're the first in the world to do it. Lay still. Lay still. Everything's okay. And we live stream for one purpose, so that we could reach out to the world and let the world see exactly how state-of-the-art spine surgery is done. We also live stream so that you can ask questions during the surgery. Shot? All right, so what I'm trying to do here, I think we're trying to get into the L4-5 disc space. Shot? And this patient's already had a fusion at L5-S1. So what you need to be doing is magging in onto the L4-5. We're seeing too much of the sacrum. You know, zooming in, magging in, whatever you want to call it. That's fine. That's better. All right, is he awake? All right, so this is Dr. Deuk. So our patients are awake for this surgery in the very beginning for lumbar. This is a Deuk laser disc repair procedure. So our patient had a fusion at L5-S1. You can see the cage in there. I did not do the fusion. He's developed adjacent segment disease now above the fusion at the L3-4, L4-5 disc. He has disc herniations and disc bulges. Those herniations and bulges are causing horrible pain for him. AP? And because of the pain, he's having back pain, chronic back pain. Very, very common problem that lots of people have around the world. 100 million people suffer with chronic back pain in the world at any given time. 100 million people. Well, the reason we're broadcasting is to let the world know you don't have to suffer with chronic pain anymore. We can fix it. When I say we can fix it, Deuk Spine Institute can fix it. Are there other places you can go? Maybe, maybe not. Most spine centers don't cure back pain. They just treat it temporarily. It gets better maybe for a few weeks or a few months, and then it comes back. But we now have cures for back pain. All right, that's our most recent lateral. And I never saw the AP. Where's the AP? You didn't do it? Oh, okay, yeah. So when I say AP, it means take an AP. All right, perfect. Go back to a lateral, please. So you can see the spine there. And this patient has a spinal cord stimulator as well. So the reason we do live stream, take another shot. Are you pulsing? Yes. Good. Always pulse. The reason we do live stream, as I said, is so that you, the audience, could ask questions. I could feel the herniation right here. I'm a little bit lower than I want to be normally in the foramen shot, so I'm hitting the back of the vertebral body. Is he still awake? All right. Shot? Shot? Are you comfortable? All right, just lay still for me, okay? Shot. We're going to be able to put you to sleep soon, but just not yet. So let's go back again and just reiterate a few points. You're watching live spine surgery if you're watching on 9/1/2020. This is the first day of September 2020. As a matter of fact, every three years our surgery center has to undergo accreditation and recertification, and it just so happens that today is that day. So we actually have our AAAHC inspectors here today doing their accreditation. Perfect blood pressure. It's interesting because this is a little more bleeding than we normally get, so I'm thinking our patient is on some type of an anti-inflammatory. We always... You stopped 8 days ago. What was it, aspirin? Huh? Ketorolac? So maybe that has a longer, you know, quote-unquote half-life in the human body. Not sure, but there's a little bit more bleeding than we normally would get, and it looks like platelet inhibition bleeding to me. There's just something about platelet inhibition bleeding from anti-inflammatories that's kind of distinctive when you see it. It's almost like immediate It doesn't seem to be under high pressure like you'd get for a high blood pressure issue and bleeding, but it seems to me to be like capillary type bleeding, just diffuse, which is typically a platelet issue. All right, so I need to see the next disc. We're doing 3, 4, 4, 5. Everybody in agreement? I'll need my mask pulled up again. I won't be using this next time. It keeps slipping down. You gotta get it around the chin and up. There you go. Thanks. Sorry about that.
It's okay.
It's not working out the way I expected. So we've made our incision on the left side. Our patient has predominantly pain on the left side of the back going down. The midline is actually right here. I don't know what this line is for. Who did this line? Was supposed to be the midline? Anyway, that's enough. I don't want to hear it anymore. Long story short, the midline is here. So most back surgeries are done in the midline. Every other spine surgeon in the world, including myself, was trained to do back surgery from the midline. But if you're doing it from the midline, you have to remove bones from the spine, and that's going to weaken the spine even more. So fusion becomes more of a necessity after that. But the technique of going transforaminal was not developed by me. It was developed by Parvis Cambin. Parvis Cambin was an orthopedic surgeon, spine surgeon in Pittsburgh, and Dr. Cambin developed a transforaminal technique, the endoscopic transforaminal technique. And only a few people in the world know it because it's difficult to do and it takes special equipment. And when Dr. Cambin did it, he had a very high complication rate of injuring the nerve root. So, you know, his students that he taught were not very inclined to do that procedure. Shot? Because they didn't want to injure the nerve root. No surgeon wants to injure the patient. Where does that hurt you? Center, okay. Shot? All right, we're going to be able to put you to sleep soon, just not yet, okay? I apologize. Shot. So the Deuk laser disc repair is a procedure. It's a novel procedure that I developed here at Deuk Spine. And the main goal of this surgery is to eliminate back pain or neck pain, depending on when we're doing it, or thoracic pain. We're doing thoracic ones now. Shot. And to do that, we have to do something very specific. We have to get the pain source. Shot. Let's get an AP. The pain source is a generic term, but it basically means wherever the pain's coming from. And the first thing we have to do, that's good, is we have to determine the pain source. So what causes pain in the spine when people have back pain? Where do you feel that? In the back. All right, lateral, please, lateral. Yeah, once you get the AP, it's always back to lateral. Don't make me have to tell you. Some of you may have noticed on that last x-ray picture that there was it looked like a computer battery thing, and that's actually a spinal cord stimulator this patient had implanted. Shot? Yeah. I did not put the spinal cord stimulator in, but it brings up an issue. People with chronic back pain many times get spinal cord stimulators put in rather than getting the right surgery to cure the pain. The stimulator just tries to cover up the pain. It doesn't really work that well either. So a lot of people come to us after they've had stimulators put in. Why are stimulators being put in so much? Because the doctor the patient goes to doesn't know anything else to do, and putting stimulators in makes them a lot of money. Unfortunately, they don't work very well. So we don't put a lot of stimulators in. We only use them as an absolute last resort when real surgery won't fix the problem. But unfortunately, a lot of other doctors that treat chronic back pain use them all the time because they pay very well, and that's all they can do to fix patients. And it doesn't really fix the problem, it just partially covers it up. The surgery we're doing today actually cures the pain. Are you comfortable? Yeah. How bad is that on a scale of 1 to 10? Okay. Now he had a discogram already, right? Yeah. Okay. So he's got a small tear here at 3-4. 6 out of 10. I don't need it. Huh? Is that your typical pain? How bad is that? What's the highest it goes to? 8. Is that where you typically have pain? Yeah. All right, you get to go to sleep now, and when you wake up, we'll be done with your surgery. Guide wire. So you just, you stay there with the fluoro, don't move. So what we did was we just injected some dye into the discs that are painful, the ones that we're going to fix. We did that for 2 reasons: to verify that his pain is indeed coming from those discs, but also, more importantly, we want to stain the disc, the inside of the disc, with a special dye that we use to look for the herniated disc and the annular tear. The Deuk laser disc repair procedure is unique in all surgeries in the world. It's the only one that repairs the annular tear of the disc. It's the first surgery in the world to ever be published to do that. This thing is killing me. No, you got to get it up over the chin. Up over the chin. There you go. A little more. That's good. Let me know. Can you count from 1 to 100 out loud, please? Shot. 1 to 100. Count from 1 to 100. 1, 2, 3. Keep going. All right. So we're going to do the entire surgery through a 7mm incision. That's the smallest surgical incision you can make. There's nothing smaller. So it becomes a Band-Aid surgery. Let me know when you're ready. So our patient is being put to sleep by the anesthesiologist. We use propofol sedation for the back and for the thoracic Deuk laser disc repair. We don't use general endotracheal anesthesia. That's for the neck. We're going to do a cervical disc herniation later today, and that patient will be getting general anesthesia endotracheal. That's with the tube down their throat on a ventilator. Shot? All right, so we're making our way down through the foramen, and you can see there's a tear. This is the L4-5. Let me know when you're ready. Huh? So we're right at the disc herniation, and we're getting ready to go into the disc. I want to make sure he's comfortable enough. Once you get started, you got to pull the guide wire, otherwise you can trap the guide wire, which you don't want to do. So you have to know the right time to pull the guide wire. So what we're doing is we're passing this dilator through the tear that's already there. Remember, it's the tear that's the painful part of the disc. The herniation itself is not painful, it's the tear. You can see how minimal blood loss we've had so far. This is a minimal blood loss surgery. We lose only usually less than 5 milliliters of blood, just a few drops. Now, if this patient had open surgery, shot, he would have lost a lot more blood. Open surgery has much higher blood loss. So the Deuk laser disc repair already, with respect to blood loss, is almost nothing. It's a few drops. Whereas open surgery, they would be pretty much a lot bloodier. All right, we're in as far as we need to go. Shot, you can move the fluoro out. So up and pull back. All right, now we've got our tube in. You all see this tube right here? It looks like a shake straw. I call it the McDonald's shake straw. This tube is, we're going to do the whole surgery through that little 7mm tube. And the internal diameter of the tube is actually 6 millimeters. So I'm going to work through a 6mm tube, which is very, very small. This is the one that's at the L4-5, okay? I'm inside the disc, and I'm going to work my way from the inside out. That's the technique that I was taught by Dr. Anthony Young. Come on, don't take all day. Dr. Young I think he pretty much pioneered the inside-out technique, okay? There are other endoscopic spine surgeons that use what's called an outside-in technique where they start in the foramen. I don't start in the foramen ever. I think it's too dangerous. It's much safer to start inside the disc and work your way out. Grab her. So we've also pushed some of the herniation that was in the foramen. We've pushed it back into the disc, which is a common technique in spine surgery when you're dealing with a herniated disc, is for the surgeon to push the herniation back into the disc and then take it out from the inside of the disc. It's safer. Then you're not working around the nerve root. Laser. Eventually we will get to the nerve root, but that's at the end when we're done. Laser on.
Laser ready. You're ready.
So the blue stain is the dye that I was telling you about that we injected earlier during the discogram. That blue is a stain that stains degenerating disc. Degenerating disc is basically herniated disc. Normal disc doesn't stain. It stays white. Degenerated disc stains blue. This is some scar tissue here that we pushed in from the herniation. When we pushed the dilator in to the disc, it pushed the actual foraminal herniation in. We're going to try to remove that in a few minutes. I just have to free it up. I think this is part of that herniation, the white thing. So let's see, laser off. The silver you're seeing is the tube we're working in. There's a piece of herniation right there. Now we take these pieces, the ones that we can, and we'll just send them off to the pathologist. The pathologist looks at it under the microscope, makes sure that it's just degenerated disc and there's no tumor or anything. Come on, Sam. Quick sweep.
We have a question.
All right, we have a question from our audience. Yes.
One of our audience members wants to know, what are some of the surgical ways you would go about fixing a herniated or bulging disc at L4-5?
What are some of the surgical ways we go... Come on, Sam. We go about fixing the herniated disc at L4-5. You need to shove it all the way on, Sam. Okay, so a herniated disc at L4-5. There's really just a few ways to quote-unquote fix the problem. The only way to fix the disc is to do what you're seeing right now. It's called the Deuk laser disc repair. It's the only surgery in the world that repairs a disc. All other surgeries either remove the whole disc. Come on, dude. You got to be paying attention. I shouldn't have to stop what I'm doing to tell you. All right. So all other surgeries remove the disc completely or remove part of the disc. And most of them put metal in. So what you really have to do to understand the right way to treat a herniated disc is you have to understand what are the symptoms caused by the herniated disc. And those symptoms, there's 4 possibilities. So let me explain, because one of the possibilities, the fourth one, is a combination of 2. So the first possibility of disc herniation is no symptoms. And that's what most disc herniations are, no symptoms. They don't cause any problem for the person with a disc herniation. So what do we do for those? Nothing. We leave them alone. We don't treat them. Will they eventually cause problems? Yes, maybe, but not all the time. We don't do preemptive disc herniation surgery. We won't do surgery on a disc herniation that isn't symptomatic. Okay, Sam, wake up. You can't have your laser fiber blocking access to this. Did you ever notice that Luis doesn't do that? It's about using your brain and making sure that those two are separate, physically in separate spaces. Do you understand?
Yes, sir.
So you have to do that, not me. Sorry. My staff still needs some work with thinking and training. All right, so option 1, the disc herniation has no symptoms. You leave it alone. Option 2, the disc herniation causes leg symptoms. Leg symptoms can be caused by pressure on the nerve root or irritation of the nerve root. What's the difference? Pressure is literally pressure, squeezing the nerve. Irritation is far more common than pressure. And irritation comes from inflammation that goes from the disc to the nerve root, the surrounding of the nerve root, which is the dura. Irritation of the nerve root is called radiculitis. Radiculitis is far more common than compression symptoms. So if the patient has leg symptoms, then you need to make sure you treat the part of the herniation that's causing leg symptoms. Then the third thing is a herniation with back pain or neck pain, if it's in the neck, obviously. A herniation with back or neck pain, can I get my mask adjusted? Comes from the annular tear. Yeah, that's good. Yeah. So the annular tear is not the herniation. It's what gives rise to the herniation. And this is where my surgery that you're watching is revolutionary, because nobody else in the world figured out that the annular tear itself is a source of pain, axial pain. Everyone thinks the herniation is the source of pain, but it's not. The herniation only causes, at most, leg symptoms, or if it's in the neck, arm symptoms. So to get rid of back pain, proper back pain, which is pain around the spine, you actually need to repair the tear in the disc, or you need to fuse the disc. So fusion is very effective at eliminating back pain from a disc problem, okay? This patient right here, we could have done a fusion on, and we would have gotten rid of his back pain. If I did my fusion at L3-4, L4-5, I could have gotten rid of his back pain, okay? And I could have gotten rid of his leg pain. So what surgeries fix what? Well, the most common surgery in the world for a herniated disc is a procedure called a microdiscectomy. And it's where the surgeon goes in and drills. Sam, you got one more opportunity, and then I'm going to kick you out of here. It's time for you to start thinking and not just being passive. Okay, so that microdiscectomy removes bone from the spine. Let's call Luis, please. The microdiscectomy removes bone from the spine. And you don't want to do that. Bone from the spine means a laminectomy, laminotomy, facetectomy. You're taking your God-given bones out of your spine. Your spine is bone, basically bone and joints. You don't want to remove any bone from the spine, ever. So when Dr. Parvis Camden developed the transforaminal technique, the whole purpose, Sam is just not performing properly. So I need you here ready to move in and take over. Dr. Camden developed the transforaminal technique to avoid removing bone. So he was the visionary. I give him credit. He was the doctor who said, you know, I think we can get to these herniations a different way, through the foramen, and not have to remove bone or joint from the spine. We're not going to destabilize the spine by going through the foramen. So Camden developed this approach to the herniated disc through the foramen that very few doctors know how to do endoscopically, okay? I mean, literally less than 1% of spine surgeons around the world know how to do a transforaminal surgery, okay? It's very rare. And you have to have very special equipment. These tubes and things that I have, they're here because I trained how to do this procedure, and I had to buy them separate from what I normally use. So what I'm saying is, if you go to all the hospitals around the country, very, very few, less than 1%, will have endoscopic equipment. The reason is the surgeons don't know how to use it. They've never been trained on it. So that's the limitation of access to endoscopic spine surgery that you're watching currently, is because so few doctors know how to do this surgery endoscopically. And then, of course, my technique is a variation of endoscopic spine surgery. So I'm the only one that really knows how to do my technique, except for those people who watch these videos and actually do my type of surgery that I've been describing for years. So we got herniated discs that cause no symptoms, herniated discs that cause back pain, herniated discs that cause leg pain, and herniated discs that cause back and leg pain. And once again, herniated discs with no symptoms, no treatment. Herniated discs with back pain, you must treat the annular tear. So whether you take the whole disc out and fuse, or you do maybe an artificial disc, which I don't think they work that well, or you do the Deuk laser disc repair. Those are really the only treatments that actually can cure back pain from a herniated disc. Leg pain curing, mostly you can do the Deuk laser disc repair. If you do a fusion with a decompression, you can treat the leg pain by decompressing the nerve root. And artificial discs are terrible, in my opinion, at treating leg pain. They don't really treat it because you got to go through the belly, and the pinched nerve is at the back of the disc, so it's very hard for the surgeon to get to. So most of them just leave it alone. And then finally, so you got fusion, you got artificial disc, you got microdiscectomy, and there's also laminectomy. Laminectomy can treat a herniated disc that causes leg symptoms, only leg symptoms. Laminectomy does not treat back pain, ever. If anything, the laminectomy may make it worse. Can we get them a little more comfortable, please? Huh? Oh, sats are dropping. I see. All right. You're doing great. Everything's okay. Just lay still.
We have another question.
I think I answered the question. If you guys need clarification, let me know. But a herniated disc at L4-5 only needs treatment if the patient has back pain from it, or leg pain from it, or both. And if you are treating a herniated disc at L4-5, if you're treating a herniated disc at L4-5, then you need to figure out, what are you treating? Back pain from it, leg pain from it, or both? If it's both, I would recommend doing the Deuk laser disc repair that you're watching right now. It's the safest, most effective surgery in the world for it. The second best option would be a fusion at L4-5 with decompression if they have back and leg pain. If they have only back pain, you can just do a fusion, you'll be fine. But most people have leg pain, and if they don't have leg pain before the surgery, they will have leg pain afterwards usually, because you're fusing them and you have to give them lordosis, which means you're changing the angulation of the spine. So you have to be aware that you're going to be closing down the neural foramen. And when you close down the neural foramen, because you're positioning them on a Jackson spinal table, you're going to end up fusing them where their nerve is getting pinched. So if they didn't have leg pain before surgery, they're going to have it after. So it's very important, if you do a fusion for a herniated disc, that you make sure you do a decompression with the fusion. And a lot of doctors don't do that because they don't understand to do that. So long story short, your options are a back and leg pain from a herniated disc, decompression and fusion, Deuk laser disc repair. Those are your two best options. And if it's just leg pain, then you can do a laminectomy, or you could do a microdiscectomy, or you could do a Deuk laser disc repair, or you could even do a decompression and fusion. But the best of all of those is what you're watching right now, the Deuk laser disc repair, endoscopic transforaminal surgery with debridement of the annular tear. Okay, That's it, laser off. You can see at 12 o'clock some veins. And then, of course, if we look up here, we should see the nerve root and the foramen. Let's see, hold on. Yeah, let's zap some of this a little bit. This is some herniation here.
We have other questions.
Sure.
One of our viewers is wondering, can you fuse C3 to C2?
Can you fuse C2 and C3? The answer is yes. You can fuse C2 and C3. Hey, we're almost done here. Just relax. Yeah, you can fuse C2 and C3. If you need to. It's not common that anyone would need to fuse C2 and C3. It's a very uncommon place. Yeah, so our patient has to be a little bit lighter right now because he's not really breathing the way we want him to, so we can't give him as much anesthetic as we'd like to. So, yeah, he's feeling it a little bit. We're right in that painful part of the disc, so. Yeah, C2, C3 fusion is definitely possible. I would need to look at your MRI because the preferential way to fuse it, laser off, would be through the back of the neck. That would be a little bit safer, I think. Can you get to it through the front? Yes, you can, but it's very difficult to. And if a patient has a big jaw, like their jaw is large, the jawbone, then you're not going to be able to get to it through the front. So the best way to fuse it is through the back of the neck. It's called a posterior cervical fusion. But like I said, it's extremely rare to need to fuse C2 and C3. So I would say send me your MRI to Deuk Spine Institute. We'll look at it for free. We don't charge people to look at their MRIs. And we'll figure out whether that's the right surgery for you in our opinion. And we'll let you know for free. We don't charge you for that. And so it's basically a free second opinion. But you know how many times I've used C2 and C3 in my entire career, 22 years? Less than 5. I've done thousands and thousands of cervical fusions, but I've done C2, C3 literally probably 3 times in my entire career. So whoever asked that question, you're asking about fusing something that really doesn't need to be fused. So it's very rare that it would be. But if it needs to be, it needs to be. I'd like to see an MRI first, and I'd like to do a physical exam and see where the pain's coming from. I'm not sure why you need to fuse C2-3. Unless you have fracture and instability.
We have another question.
Yeah, so before I take the next question, let me just explain what we're doing here. Let go. You're missing the muscle. That's why we're bleeding. Okay. We're going to put some pressure. Just hold it. Yeah, put both hands. So we've made one incision. We're going to fix both discs through one incision. We've taken the tube out. There's a little bit of oozing from the muscle, still under 5 mils of blood. And we're getting ready to do the second disc, which is the L3-4. Now we know this patient has painful discs because he had a discogram done before surgery. And the discogram is basically the same thing I'm doing, but without injecting the blue dye, just injecting dye. And we've verified that this pain is coming from L3-4 and L4-5. Now, when I met with him and I told him about the results of the discogram, essentially that his pain is coming from the L3-4 disc and the L4-5 disc, I said to him, look, you have a choice. You can do another fusion above your other fusion for adjacent segment disease, or we could repair the disc with a laser. And truly, when I looked at his MRI, I felt the laser surgery could easily repair the discs, the tears that were causing the pain, the posterior annular tears that were causing his back pain, and that the surgery could be successful and should be successful. I didn't see any reason why it wouldn't be. So I could fix his pain without putting him through another fusion. Now the fusion he had done before, you can see it at the bottom of the x-ray. So let's go ahead and take a quick x-ray. Now you see there's a cage there, right? You see that metal cage at the bottom right of your screen? That cage was put in through the front. All right, it's called a BAK cage, BAK cage. It's been around for like 20 years, maybe longer. And originally when we did fusions on the lumbar spine, we did it kind of through the belly because you could get to the inner body space, which is a big space for fusion, and you have a higher chance of a successful fusion when you do an inner body fusion. Inner body means between the vertebral bodies. So until a surgeon about 20 years ago developed a technique where you could go through the back and get to the inner body space, through the back. And that was the most advanced technique in the world at the time. That's what I learned in my training. I learned how to do these surgeries through the back with one incision in the back. But remember, a lot of surgeons were trained without the benefit of having very, very good training, or they were trained before these newer techniques developed. And so they have the older technique. And the older technique was to go through the belly, so to make an incision in the belly and go in the front of the spine and put in a BAK cage. The problem with that surgery is lots of bleeding, and usually the patient would lose the ability to have an erection if you're male. And of course there would be female sexual dysfunction. And the reason for that is that there's a plexus of nerves on the front of the spine, and when you go through the belly and you go through the front of the spine, you're going to damage those nerves. So it's not very popular to go through the front, through the belly, to do cages anymore, but there's surgeons that do that all the time because they don't know how to do better surgery, basically. So there's a lot of patients out there getting fusions through their belly still when they really shouldn't be, but that's all their surgeon knows how to do. And the surgeons aren't going to hang up their hat and quit surgery just because they don't have the most advanced techniques. Well, at Deuk Spine Institute, we have the most advanced techniques. And in doing over 1,100 of these laser surgeries, we've never had a complication. We're not going to start today. So the safest surgery in the world for a herniated disc, as well as the most effective surgery in the world for back pain from a herniated disc and leg symptoms, is the Deuk laser disc repair, what you're watching right now, which is why we offer it to our patients, because it is the very best. All right, are we ready to move on to the next disc? Yep. So we're going to start on shot. We're going to start on L3-4. You need a what?
I need a
Dilator. Are you ready? All right, Sean, sorry about that. What is the other question we have?
We were wondering, can a lumbar disc re-herniate after you've repaired the annular tear?
So great question. Can the disc re-herniate after I've repaired the annular tear? The answer is 100% yes. The disc can re-herniate after I've repaired the annular tear. That's why we give all of our patients restrictions on lifting and bending until the disc has healed itself. So what I'm doing with the annular repair is I'm debriding the annular tear and removing the herniation that's stuck in there. Okay? Let me know when I can proceed, doctor. By debriding the annular tear, I'm giving it the chance to heal properly. Without my debridement, the disc will not heal, ever. It just stays inflamed. It stays in pain. But by debriding it, by debriding the tear in the back of the disc where the herniation is, that gets rid of all the pain fibers that are in there that have grown in and are causing the back pain. Huh? So by debriding the annular tear, I've cut back all the inflamed tissue, all the scar tissue that's in that tear, and I've gotten rid of the little nerve fibers that are grown in there that are causing the pain that the patient is feeling. And I've cut back to fresh, clean annulus. And that annulus then will heal itself, but it takes a year to fully heal. 1 year to fully heal. And the disc does not heal quickly because, well, it doesn't have much blood flow. It doesn't have a big blood supply. The inside of the annulus has no blood supply. So just let me know when I should proceed. Shot? All right. Shot. Shot.
We have another question.
Sure.
Can DLDR treat spinal stenosis?
All right, I didn't hear the question. Shot?
Can DLDR treat spinal stenosis?
Can Deuk laser disc repair treat spinal stenosis? The answer is yes. It can. Sorry guys, hold on a second. Want to make sure this goes in properly. Shot. All right, so right now I've got the dilator in the center of the disc through the tear, but our patient's moving a little bit more than I want him to. How are we doing, Dr. Arcos? We're going to be able to move forward at some point? All right, we're just trying to get our patient a little bit more comfortable. Remember, these are painful discs, so as I pass through the tear, it hurts. If you noticed, I passed through everything else, the skin, the muscles, the fascia, nothing hurt him. But when I got to the actual disc itself, and we started to push the dilator through the tear, he reacted very strongly because this is a painful area for his body. The first person to discover that the disc itself is painful was Cloward. Cloward was a spine surgeon back in the 40s, 50s, 60s, and he did some tests back in the days when I guess experimenting on humans was still allowed. But he's not a bad doctor, not a bad guy, and he's a pioneer, obviously, in spine surgery. But he actually got in the operating room, and when he had patients' backs open, he would push on the back of their disc when they had a herniation. And he found that he could reproduce their back pain just like I'm doing right now by pushing on the back of the disc. But the sides of the disc weren't painful. The front of the disc wasn't painful, just the back. Can you reach over and pull up my mask? Just come over here. You can reach over there. It's not a big deal. She knows. That's good. Perfect. Thanks. So, I know Dr. Cloward published this in a paper. Are we ready? Shot? Shot? Let me have that quickly. Shot? I think that's probably good. Take. So yes, Deuk laser disc repair can treat spinal stenosis. So what is spinal stenosis? It's narrowing of the spine. What causes it? There are different causes, but commonly it's disc herniations can cause it, bone spurs can cause it, ligamentous thickening, take the fluoro out, can cause it. Facet hypertrophy can cause it. Collapsing disc can cause it. So there's a variety of causes, folks. It's not just one. And usually, unless it's a herniated, I need a scope on, please. Unless it's a herniated disc causing the spinal stenosis by itself, it's usually a combination of things, okay? Some people are even born, laser, with spinal stenosis. About 20% of the population has spinal stenosis when they're born. And it's just from having pedicles, which are the bones that connect the back of the vertebral body with the posterior elements, the facet joints. So 20% of the population has really short pedicles. These are bones in their spine that set the diameter of the area where the nerve leaves. They're called the neuroforamen. And when you have a narrow neuroforamen that you're born with, then it doesn't take big herniations or a lot of structural abnormalities. Let go of that, please. You're pulling on me. It doesn't change a lot of the, it doesn't take a lot of structural changes in order to make the stenosis worse and what we call symptomatic, okay? So lots of people have stenosis of narrowing of their spine from little disc bulges or thickened ligaments around the facet joints or thickened facet capsule, or even listhesis, a shifting in the positioning of the bones in the spine. So there's lots and lots of causes of stenosis, but most people with stenosis have no symptoms. So it's really my job, a really good doctor's job, to figure out, is your stenosis symptomatic? Is it causing your problem? And I can tell you a lot of doctors screw this up. They think patient with lumbar spinal stenosis, oh, patient has leg pain. Let's go fix their stenosis with surgery on the back. They do that, but the patient still has leg pain. Why is that? Because the leg pain wasn't coming from the stenosis. It was coming from their hip. They maybe had arthritis in their hip that was undiagnosed. Or their leg pain was coming from the piriformis muscle in their butt cheek. Or their leg pain was coming from a problem with their veins in their legs, not their spine. God, come on, guys. You know, so there's a lot of different causes of leg symptoms other than stenosis, or arm symptoms other than stenosis. So you have to go to a doctor who's able to make the right diagnosis. How do you know you have the wrong diagnosis? Well, you can let the doctor operate on your back and then find out it was the wrong diagnosis, or you can go to a place like Deuk Spine Institute, where we have a very high success rate with our treatments because we make the right diagnosis. Okay? We don't perform magic here. We just are very good at the basics, and the basics are the physical exam, the history, making the right diagnosis, using basic tests like MRI, CAT scan, X-ray, nerve test, and sometimes a discogram is necessary. But when you use those basic tests and you interpret them properly, then you can make the right diagnosis. And I can tell you that if you go somewhere where there's a spine expert, there's about at least a 75% to 80% chance they're going to make the wrong diagnosis, okay? And I'll tell you why. Number one, they don't have the right tools to make the right diagnosis, or they don't have interventional pain management, which can confirm the right diagnosis, okay? So you need to have all those tools. You have to be able to interpret them, and you have to have interventional doctor who's very good at what they do to be able to numb up certain joints and muscles to confirm the diagnoses, okay? So it really requires a multi-specialty group practice that has access to very, select amount of information to be able to make the right diagnosis. Now, is this something that we could do everywhere around the world? Absolutely. But doctors have to be retrained. Right now, they're not trained properly to make the right diagnosis. Okay? They need proper training, proper experience. As a matter of fact, I didn't even get trained properly in my residency to make the right diagnosis. I had to learn when I got out of residency how to make the right diagnosis about the causes of back and neck pain, because I wasn't given the proper tools. And I went to one of the best training programs in the world at UF in Gainesville. It's just not being taught, is what I'm telling you. I had to self-learn. I had to learn from experts in the field. I had to learn from my own patients and my own experiences. I had to learn from Dr. Patel, one of the best interventionalists in the world. I had to learn from Dr. Schrumpf, one of the best therapists in the world. I had to learn about things like piriformis muscle pain and dysfunction. I had to learn about sacroiliac joint dysfunction pain. I had to learn about all kinds of coccygeal ligament pain, all kinds of stuff that neurosurgeons aren't taught, orthopedic surgeons aren't necessarily taught. So how can you diagnose something when you don't even know it exists? How can you diagnose something when you don't have the tools necessary to make the diagnosis? And that really is, in my opinion, the biggest problem with making the right diagnosis in the United States today, is that most doctors don't have the right tools. Almost done. I know. All right, laser off. Wait, I gotta get this last piece here. Let me have a grabber.
Another question?
Yes, I don't know, did I answer that last question?
Yes, you did. One of our viewers is wondering, can you explain foraminal narrowing? Is this procedure part of a decompression?
Okay, so can you explain foraminal narrowing, and is this procedure that you're watching part of a decompression, I believe is the question?
Yes.
All right, so foraminal narrowing, just to kind of make it simple, is the spine is a structure that is long, goes from the bottom of your skull down to your tailbone. But in the center of the spine, that's where your nerves run. It's protected. Those nerves are very delicate. They're very soft. They have to be. All right, nerves are made up of myelinated axons. And axons are very, very soft structures, okay? Done. We're done. I'm gonna come to the conference room and answer that a little bit better, okay? You guys got it?
I got it.
Let's show the audience what the whole surgery was done through. Can you see here?
Star cleaning, please.
Yes, we can.
All right, so
You can turn off the mic.
can you see the scope?
Yes.
All right, the scope has two parts. It's got this long metal part that goes inside the tube, and this is called an endoscope because it goes inside to the human body. And all the work that we've been doing has been at this end of the scope, right there, where there's a light, there's a camera, a lens that brings an image back to the camera, which is in my hand. There's also holes where I can put the laser and a hole where I can put the grabber, and then there's suction that sucks the water out, okay? Then back here you have the camera right here, which attaches to the back of the scope, so it allows me to see what's at the tip, okay? And all the work is done through this portal right here on the endoscope, all right? So all this is done through a tiny little incision. You could see my finger here, it's about 7 millimeters. It's about half the width of a dime, okay? We lost probably 5 mils of blood the whole time, just not much blood at all. I've got a Raytech off. And we're done, basically. So this patient will take an hour to recover and then go home. The reason why he was moaning and groaning a little more than normal patients do is because he has sleep apnea, and so we can't put him too deep, otherwise he'll stop breathing, and that's worse than having some discomfort. Let me come over there, and I will answer more questions, guys and gals, so please type them up, and I'll answer the other question a little bit better as well.
That was probably one of the things I noticed right away was that I had some control again, which was kind of cool, You still have that sort of, your brain's relearning where things are again. So now that you're back to getting healthy, it's starting to come back. You're starting to feel like you're able to play. But yeah, I'll play, this song is called Oscar the Grouch Goes to the Movies. So yeah, we're a pretty musical family here. We play a lot of shows. We're in a band called Positive Chaos, and this is my bass. Picked it up a little while ago. We use it for acoustic shows. This is actually our guitarist's acoustic guitar. He actually just moved down here from Connecticut, so it's kind of cool having him down. This is our violinist and my fiance's violin, who has been in the band with us for a bunch of years now, and she's having some fun with that. This here's my acoustic guitar, which we'll be hanging out with later. And then this is our drummer's bassist of all things. So yeah, that's that guy. And a couple months ago, it'd be pretty much impossible to pick this guy up off the wall without some pain. So it's kind of cool that I'm able to start doing that again. From here. And I'm waiting for you. So that was cool. At this point, I wouldn't have been able to do this, I don't know, a month ago. And now I'm able to play guitar again. So it's kind of nice getting back. And Getting the band Positive Chaos back together is going to be pretty fun, and we're really looking forward to it. Thanks, Dr. Deuk. We know this is the way to live, and you keep on calling. Yeah, so my name is Dave. Last year I was in a auto accident. It was August. T-bone accident in the area. Suffered some neck injuries. Basically kind of spent some months just kind of dealing with it. Then decided to talk to a chiropractor, started looking at it. From there, I did the epidural injections. Those were pretty successful. I was feeling a little better. And then woke up one day early, I think it was March, and I was agony. Like, I couldn't move, couldn't lift my arm, aggravating the bottoms of my fingers, like everything hurt from the base of my skull down to all the way into the very base of my pinky. So it was kind of tough. Like, you know, everything that you did is now different. Like everything hurts, and it, you know, makes you irritable. It's like this like burning, stinging pain. So you kind of spend a lot of time like going around things. You spend a lot of time like tiptoeing through what you can and can't do. So I decided it was time to see somebody about it. So I went and found Dr. Deuk Majan. You know, you spend a lot of time going to different doctors' offices for something like this because you don't really know. You're looking for something to fix you. So I actually found Dr. Deuk Majan online. Like it wasn't like a referral sort of deal. So I go into the office and it's bright, which is different. A lot of doctors' offices are dark and they're kind of scary. So you go in and everybody's pretty happy. You're like, okay, this is a change. And you know, you talk to the staff there and they're excited to see you. Not only that, but they booked me the day after. Like I called them and they had a spot for me the next day. That was huge. So, you know, you go in there and you're talking to them and they're exuding this like sort of air that things are going to be okay. And they send you in and I met with Dr. Deuk Majan's assistant, Luis, who's a great guy. He started setting me up and he's going through the x-rays and kind of saying like, hey, listen, this is what you got going on. Dr. Deuk Majan's going to come in and explain it further to you. So Dr. Deuk Majan comes in and he's got an air of confidence about him. You feel better when he's talked to this guy. And I remember him saying like, you know, you're in trouble. You have some issues here. But as he left, he was like, but we're going to patch you up. And that was the first time that I didn't feel fear in like 3 months. It was the first time that you felt good. You felt like, we're going to be okay. We're getting back to being okay. And that was a huge thing. Like this confidence that he had, this swagger that he had where he came in and he was like, we're going to patch you up. And that was it. And it was like, all right, that's huge. Like that was a huge feeling. Yeah, when I woke up in surgery, I noticed that it felt like a garden hose had unraveled in my arm. Like I could feel things again, like it wasn't this like wrapped up tight pain. Like yeah, there's obviously surgical pain involved there, but it's, you know, you feel instantly better than you were. And it's kind of this, it's no longer like shooting down into your arms. It just feels like things are starting to heal, like things are back in the order that they should be. They're back kind of feeling the way that they should. So, and that was something I noticed that day. Like, you know, you're a little groggy from the medicine and all that stuff, but at the same time, you feel better, like instantly. If you have neck pain, like, or back pain, anything spinal, like these are the guys to talk to. These are the best in the business. Like this is what they do. And yeah, I'd highly recommend them. I would recommend them friends, family, strangers, absolutely. Like yeah, I would highly recommend Dr. Deuk Majan. That's the end of it right there. So definitely. Since the surgery with Dr. Deuk, I'm able to get back to what I love to do, and that's the best part of it. Like Dr. Deuk set me on the path to getting back to doing what I love. So that's huge, and that's awesome. My time, ooh, and I'm waiting for you. Thanks, Dr. Deuk.
Wow.
Cool.
That's amazing.
Thanks.
Okay, Dr. Deuk Majan back with you folks. And I just left the operating room. Our patient is doing well. They've moved the patient to the recovery area of the surgery center where he'll spend about 30 minutes before he goes home, just waking up. We use propofol for our anesthesia. Propofol is truly the best drug in the world for this type of procedure. It's expensive, but it's really, really good. The only thing about any anesthetic agent is that it can make the patient go to sleep really deep. And when some people are asleep deep, they stop breathing, okay? And we can't have that, obviously. That's not safe for the patient. But people do it all the time at home. It's called sleep apnea. They stop breathing during the night, and then they pick up again and start breathing. It's okay to do surgeries with sleep apnea patients as long as you manage their airway properly during the surgery and afterwards. And so we do that. We've never had a patient die in our surgery center. We've never had anybody lose their airway or become compromised. So we've always practiced, what is it? Oh yeah, thanks. We always practice the anesthesia on the safe side of being less rather than more. What is this?
This is the patient side.
You gotta get this done when I'm there. All right. Anyway, this is a live stream. We don't edit these surgeries. These are live. They're live because I choose to make them live for no other reason except to bring the audience into the operating room and the experience of the operating room. I want everyone to see the absolute truth of what happens. We're not hiding complications. We're not hiding results. We're not hiding anything. And, you know, I can't hide the fact that I'm a quarter Irish. And so when I get upset about people not doing their job right, I'm going to rip their assholes apart, and you're going to hear all about it, and that's okay, because that's just me, and honestly, I'm not here to get an Emmy Award or a Golden Globe or whatever it is they give actors. This is just real spine surgery. This is reality TV. It's, you know, it is what it is. There's a lot of surgeons who are a lot worse than me, trust me. They throw instruments when they get angry. They punch people. I don't do that. I just yell at people a little bit, so I think that in my personal philosophy is if you have an employee who's not doing their job properly, they're not focused, they're not doing what they're supposed to do, I'll tell them, you know, and it won't be nice and sweet and sugar-coated. I'm going to let them know that I'm pissed off that they're not doing their job right. So you're going to hear that throughout the day. You're going to hear that throughout the surgeries. You'll hear me be happy-go-lucky kind of guy, which I like to be, as long as everyone does everything properly. Okay, but when people start screwing around and not focusing, and I've got a great team, don't get me wrong, and I'm going to tell you something, the people I've got working for me here are better than any hospital. I've been in many hospitals. I've been the chief of staff at a hospital. I've worked as a chief of staff for 2 years. So there's a lot of screw-offs everywhere in the hospitals, particularly. The hospital culture is very different than a surgery center culture. Hospitals tend to attract workers that are pretty lazy and don't want to do very much. So you can imagine how I feel about those people. They don't last very long with me. And that's one of the reasons we built our own surgery center, was to get away from the hospital culture and way of doing things. Hospital culture is, in my opinion, is very toxic. We need our hospitals, but we don't need them for me to do my spine surgeries. That's why we built the surgery center at Viera, to have state-of-the-art equipment, state-of-the-art medications, and state-of-the-art staff. So when my staff let me down, I'm going to let them know, because I want people to be alert and attentive. I don't want them making mistakes. There's a human life at stake here. There's a human life at risk. It's not my life, it's my patient's life. So when my team gets sloppy, they make mistakes, that's when I'm going to get very angry with them. So I get angry at people when they do things that could potentially jeopardize patient safety. And so that's what you're going to hear from me. Why am I talking so much about this? Because it's important. So let's get back to the question, what is foraminal stenosis? And I was starting to explain that there's really 4 zones to the spine where nerves run. And those nerves are, think about them as like being cables, okay? They're very soft, delicate cables. They can easily be crushed, very easy. The forces that are found in the spine are powerful. The weight of your entire upper body from your belly button up, it's about probably close to 100 pounds, maybe in some people, in the average American now, it's about 100 pounds, maybe 80 to 100 pounds. That's a lot of weight. All that weight gets transmitted to the spine, to the bones in the spine and the disc. So the nerves run past joints in the spine, the disc and the facet joints. They run through this structure that is constantly under loads, heavy loads, and so these very delicate little cables are basically running near very powerful machines and joints that are moving and could crush them. So they need to be safe. They need to be close to those joints but not compromised by those joints moving. So when the spine gets out of alignment and one of those joints that's very powerful, very hard, very strong, starts pinching on a nerve that's very soft because the nerve is running next to that joint, then you can start getting some nerve damage. So what happens in stenosis is you get a narrowing of the spaces, the holes, the channels where these very delicate nerve cables, where they run. And normally those nerves have enough room, just enough room, because they're literally up against these joints, like the disc and the facet joints. They're right up against them. So that if the disc or the facet joint enlarges over time and gets bigger, it's going to be pushing on those delicate nerves. And that enlargement of the disc, enlargement of the facet joint, that causes a narrowing of the space where the nerves run is called stenosis. It means narrowing in Latin, stenosis. So there's really 4 zones of the spine where the nerves run: the central canal, the lateral recess, the neuroforamen, and the extraforaminal area. Extraforaminal is really not important, so you can forget about that one. But where you get the most nerve compromise or pinching of nerves that causes problems for people with leg or arm symptoms like numbness, tingling, sciatica, weakness, that comes from 2 areas of the spine, most commonly: the lateral recess and the neuroforamen. The neuroforamen is actually a hole where the nerve leaves the spine and goes into the arm or leg. If the neuroforamen's in the neck, it goes down the arm. If the neuroforamen's in the lower back, the nerve goes down the leg. There are 5 nerves on the right side of the neck that go down into the arm. They control all your muscles and all your skin. And they also take sensation from what are called muscle spindles and Golgi tendon organs, which are sensory organelles that tell you proprioception or position of your digits or limb in space with your eyes closed. So it's complicated, but basically we think of the nerves as having both sensory and motor functions, which means they control movement of the arms or legs, and they control basically through your strength, and they also can control sensation. So when the nerve gets compromised or pinched, you can lose strength in an area of your arm or leg, or you can lose feeling, okay? So as stenosis gets worse and the nerve gets crushed more, you're going to lose more function. So that's why we do physical exams. We examine patients' strength and sensation to determine how bad the nerves are being compromised. The most common location, as I said, was the neuroforamen, which is the hole where the nerve comes out, either in the neck or the lower back, and it goes down the arm if it's in the neck, or down the leg in the lower back. And you have a right side and a left side. So you have 5 nerves coming out through 5 holes in your neck to make up what's called the cervical plexus, which those nerves then divide and go down into the arms to innervate muscles and skin for strength and movement as well as sensation. Same thing in the leg. You have 5 nerves on the right side, 5 nerves on the left side. They're, basically paired, and they go down the right and left leg respectively. So any one of those 5 holes or neuroforamen could get narrowed and pinch on that nerve. Okay? So spinal stenosis is something the Deuk laser disc repair does fix. The Deuk laser disc repair goes through the foramen, so we're able to get to the foraminal narrowing immediately, right away. Whereas traditional spine surgeries that everyone else does, besides Deuk spine, they have to remove bone in the back of the spine in order to get to the neuroforamen. We get to the neuroforamen through the front of the neuroforamen. Other surgeons get to the neuroforamen with microdiscectomy, laminectomy, or TLIF through the back of the foramen. What's the advantage of getting there through the front? Well, the pressure on the nerve is through the front of the foramen where the disc herniation is. Disc herniations are in the front of the foramen. They contact the nerve root leaving the foramen in the front of the nerve root and push it. So why do treatments through the back of the spine work? Because they have to open up the back of the foramen by removing the lamina and facet. They reach around the nerve root and then start pulling out herniation from the back. Very risky, very dangerous, not as effective. The Deuk laser disc repair attacks the stenosis at the source, which is the front of the foramen or front of the nerve root, by removing the herniated disc and bone spurs in the front. Did I answer that question? Okay, I'm going to give this mic back to Sean, and Sean will give us the next question. Oh, no more questions. Great. Well, I hope you enjoyed the Deuk laser disc repair on this patient, who you all saw that had a prior fusion at L5-S1 through his belly, not by me, but by another spine surgeon. He did not want to go through that again, so he chose to do the Deuk laser disc repair. We'll check on him in about 15 minutes and see how he's doing, okay? And we have another laser surgery coming up in about 20 minutes. This will be an anterior cervical. This lady has a herniated disc in her neck at C5, C6. The herniated disc is on the right side, and it's pushing on the right C6 nerve root. She has numbness in her hands, she has weakness in her arm, and she has pain shooting from the base of her neck into her shoulder and arm, called cervical brachial pain. She's got 3 herniated discs, C4-5, C5-6, and C6-7. Only one of them, C5-6, is hitting that nerve root on the right side, causing arm symptoms. So we're only fixing the one disc today. The other ones aren't causing any symptoms. And I know that because she didn't have any symptoms at all prior to a few days ago when she started developing the pain, numbness, and weakness in her right arm. And there's only one disc herniation on the right side, and it's pretty bad. Okay, so we'll be doing that today. The patient needs to be put to sleep first. She's going to have a tube put down her throat. She goes under general endotracheal anesthesia, and then we're going to do the surgery. This is a very unique surgery, and Dr. Deuk Mage and myself, Deuk Spine Institute, this is the only place in the world you can get this surgery done. Everyone else would be doing an anterior cervical discectomy and fusion or an artificial disc. The Deuk laser disc repair fixes the herniation without removing the disc. It's all natural. And there's no metal or anything put in the patient's neck or body. It's all done through a 4mm incision. So this next surgery is pretty special. We don't get a lot of cervical Deuk laser disc repairs. There's usually about 3-to-1 lumbar to cervical. So this one will be a special surgery for you to watch.